Welcome back, everybody. This is going to be KRS 420, Chapter 4, Injury Nomenclature. This chapter is very important because understanding the definitions or nomenclature is essential for being able to optimally treat patients, especially amongst different providers. So understanding the language that everybody's using is important. Right, so this chapter is mainly going to focus on a lot of definitions. Some of it may be familiar, some of it may be a little bit more in-depth. So it's all about communication. Okay, so we've already mentioned different types of swelling or fluid accumulation. We've learned that edema is outside of the joint capsule. So think if you had like a really bad muscle bruise or a strain of a muscle, the cells of that tissue is injured, and then the contents spill out, then you definitely are going to get some inflammation and inflammatory cells migrating to the area. So that's what the edema is. When it occurs inside of a joint capsule, we call it effusion. So if you think about the knee, when the knee is filled with effusion, that limits the things that can be injured, right? So inside the knee joint, you have the cruciate ligaments, anterior and posterior, the medial and lateral meniscus, then the joint articular surface, sorry. So that's the slippery part of the end of the bone. Then of course you have the synovial fluid. So when we think about different types of fluid accumulation, it tells you, if you can understand is it inside or outside of the joint capsule, then it limits the injuries in your differential diagnosis. Okay, so I know you've all heard of macro and micro trauma before. So if we think about this picture C, let's start here because this is healthy. We're looking at a sagittal, so we get a left and right view of inside of the knee joint. So here we have the femur, gastrocnemius muscle coming up to the posterior part of the femur, right? So this is the gastroc. Hamstrings are going to be coming down. So this one is the hamstring. Patella, tibia. You see a little bit of the menisci and the tubercle in the middle of the joint. So now that you're orientated, this is your quadricep and patellar tendons, right? So it's one continuous structure, but we just name them. On the superior part, it's the quad. Inferior part is the patellar tendon. It's solid and black, so on this MRI, this is a healthy patellar tendon. Here you can see a little bit of white discoloration, and here you see a lot of white discoloration. So this is a person with patellar tendinopathy. So you can see that the tendon, instead of being solid and black and healthy, the white areas where there's either kind of fibrillation breaking up of the collagen fibers or swelling. So there's fluid in it. And then, so that's an example of micro trauma, right? So if this is a runner, a basketball player, someone who's jumping up and down, someone who has a high workload, this might have been their first MRI where they saw they had an injury, and then over maybe like 3 or 6 months, they saw the improved changes in the tendon quality over time. Then the bottom picture, you can see from the normal or healthy looking one, we see this little bump here. This is a patellar tendon rupture, so macro trauma. When the tendon ruptures, you can see the patella has slid superiorly. You can see where it's resting here. So it's not directly at the joint line, but it's a little bit above. And you can see where it's centered on that curve of the femur. Here it's completely above the curve of the femur, because when the tendon ruptures from down below, you can see there's no solid black line here. With a macro trauma event, that patella is going to move superiorly. So that's one of our signs we're looking for. Okay, so thinking about the different forces that cause injuries, one of the main ones for sprains and strains are going to be tensile forces. So the picture on the right, remember, those are the lines of the collagen fibers of either like a tendon or a ligament. So if we think about how the cells are lined up, right? So the tendons and ligaments are in relatively straight lines. So they handle tensile forces well. So if you think about your patellar tendon, when you jump up and down and you move between flexion and extension of the knee, it's able to absorb those forces, right? Because it's in the line of the force development. Think about this example of going to kick a soccer ball. Sometimes we get overstretching injuries. So think about what muscle is stretching at both the hip and the knee joint. So you have to remember, when we're eccentrically loading, there's a greater force development. So what muscle crosses the hip and the knee that is stretching? So if we move into hip extension and knee flexion, you're going to be stretching the rectus femoris. So being able to develop that eccentric force in two joint muscles is good, right? When you stretch a muscle, you store kinetic energy. And as long as you stretch and then concentrically explode, that energy is returned to the concentric motion. If you pause and hold it, you're obviously going to lose that kinetic energy. But I just want you guys to think about, tensile forces, how the tissues are in the same lines of the stress patterns, in the triplanar movements, and then how two joint muscles have even greater amounts of force applied to them because you're crossing two joints. So a little bit further, two joint muscles, very common to have strains. Rectus femoris, very commonly strained. The gastroc, the hamstrings, those are all two joint muscles. And we see a lot of strains in those muscles because of the fact that they cross two joints and they have more force applied to them. Versus something like your soleus in your ankle. We typically see a ton of gastroc strains, but you don't hardly ever see soleus strains. Okay, so other types of forces, we typically think of bones. So compression, obviously if the two ends come together, landing from a jump, especially in the tibia. Remember, the tibia has a little bit of a curve to it. It's not completely vertical. So if there's tibial bending, you might get additional tensioning. So a combination of compression and tension. Because we know the tibia is common to have stress fractures. Shear forces are moving side to side, so you can see that here, right? Shearing. Torsion is a twist or a rotation where the bones are moving in opposite transverse plane directions. And then of course a direct blow. So remember, if we think about this bone, the compression side is able to absorb the forces better than the tensioning side. So when the bone usually breaks, think about like if you took like a chicken wing and you start to bend it, it'll first break on the tensioning side that's being stretched versus the side that's being compressed. Okay, so talking about muscle strains, remember, it's usually a tensile overloading. So it's either going to be eccentric where you're overstretching and rapidly loading it, or coming down into like a very strong concentric contraction. Often it occurs at the muscle tendon junction, right? That's one of the weak spots in the muscle. And of course we grade them. So grade 1 is going to be the most mild. So typically if it's just an overstretching, you're not going to get that much cellular damage. So you wouldn't expect a lot of swelling. They might be a little point tender when you palpate. When you stretch it during passively, let's think about a hurdler or a track and field athlete who's sprinting and they have a hamstring strain. Usually the passive flexion part, so shortening the hamstring wouldn't hurt. But if you brought them up into like a straight leg raise and you started to stretch that hamstring, it might be a little painful at the end range when it's really compressing at the end of the range of motion, right? So typically during the stretching part. Okay, and then pain, right? P exclamation, pain with resisted or any manual muscle testing, right? That one should be pretty obvious. For a second degree here, we can see some ecchymosis, which is the purplish discoloration we get. So obviously if it's in the muscle, this is edema, and the purplish discoloration, remember, if the capillaries and small little arterioles and venules, parts of the vascular system, if those cell walls are torn, the red blood cells are escaping from the vascular system and they start moving into the interstitial spaces between the muscle fibers or between different layers of muscles or the fascia or the subcutaneous fat and skin. And when that purplish discoloration or bluish discoloration settles in, it's usually going to be gravity dependent. So it's going to start to sink down. So even though you have a hamstring strain up here, maybe it's most point tender in the muscle belly, you can see it's drifting down through that posterior compartment and even into the shank and gastroc region, right? Gravity dependence. It can be your friend or it can be your enemy, depending on the situation. Okay, so obviously, when we think about the things we see in the evaluation, with a grade 1, it just hurts during the resisted, maybe when you stretch the muscle all the way. But now anything active, passive is going to be really sore. Like if this guy tries to do like even a standing hamstring curl, it's going to be really point tender and sore in that injured muscle belly. Then grade 3, complete tear of either the muscle fibers or the tendon itself, right? So grade 3, complete rupture of muscle fibers or tendon. Total loss of function. They still might be able to do range of motion. Think about, your hamstring has 3 parts to it. Well, actually 4. Semimembranosus, tendinosus, and then 2 heads of the bicep, so short and long. Imagine if you just tore semitendinosus, you'd still have the other 3 parts of the hamstring there. So you still might be able to do knee flexion, but they're going to be severely limited in their ability to flex, hold it against gravity, or even to like walk or run. Okay, tendinopathies. So this next section, moving and transitioning from the muscle fibers to the tendon itself. Remember the suffix itis and osis, right? Anytime we see those, itis refers to the inflammatory process. So think about the leukocytes, the white blood cells, macrophages, things that are in the acute inflammatory phase, the first 3 days after injury. They're attracted to the injury site to clean up debris. So any of the muscle fibers that are ruptured or torn, you basically have to cut those out and get rid of them. And then they're the chemical mediators that start attracting the platelets, which have all the growth factors in them, which help stimulate healing in phase 2, right? Or that's where you're creating proteins, collagen fibers. If it's the muscle, obviously we're going to need actin, myosin, right? All those different types of proteins. Okay, and then kind of a third kind that is very specific, tenosynovitis or tenosynovitis, refers to the synovial linings around tendons. Right? So this is inflammation that occurs in the synovial sheath or a synovial lining that wraps around the tendon. Typically, we see those in the hand and fingers, so you'll get that in 421. Okay, so in the resource tab, there's some optional reading if you want to learn more about what tendinopathy is. There's been a lot of debate in science the last 20, 30, 40, 50 years. So it started as it's pure inflammatory, and then it kind of rebounded to, well, it's more of a breakdown, a tendinosis, because there's fewer collagen fibers, and now it's kind of met in the middle where it's like, well, it's a combination of the two occurring simultaneously. So people who have tendinopathy, there's an increase in inflammatory cells that are in the injured area, and there's also a breakdown of the collagen fibers, right? So the only way to reverse this tendinopathy is rest and rehabilitation. Think about it as a math equation, right? So if the tendon has too much work and not enough recovery, that's the recipe for tendinopathy. So what goes into recovery? Nutrition, activity modification, strengthening exercises, flexibility training, and then there's also a genetic component to it. So sometimes you're just unlucky. Some people just have not as good DNA and protein synthesis versus some people who are never injured. Okay, so we grade them. Remember, this is the overuse grading scale that we saw a few chapters back. So it's pretty much the same. So grade 1, it just hurts maybe at the end of practice or a little bit, but after they're warmed up, it feels better. Then maybe only during the eccentric phase of manual muscle testing. Not likely to have swelling at this point. With the grade 2, it starts hurting during and after activity. So that's the key factor. right? Once it's hurting during or after their activity, and then they start having some dysfunction in their sport or activity. And of course, grade 3, first step in the morning is the worst, and it hurts all the time. So grade 3 tendinopathy, like in the Achilles, it's very, very severe. They're probably limping, and they're not able to walk. Okay, next injury. Myo refers to the muscle. So if we have an inflammatory condition of the muscles where it looks like there's bone formation, right? Ossify refers to ossification of bone. So think about a really severe hematoma or bruising on the quad of like a football player. Let's say they get tackled, they get a shoulder directly to the quad, and then they have a bruise. That is, like we said before, the vascular system, like all the contents of the capillary beds have spilled out into the muscle fibers. That's not good. You want your body to reabsorb that. So as long as it's covered and it heals normally, the person's fine. But in cases where they continue to go back to practice, the bruise never heals and they continually get hit there, that intramuscular bleeding, remember you have a lot of calcium, potassium, other minerals in the blood that's being transported, and that's what starts to ossify. Right? So we always use ice and stretch because they have reduced range of motion from the hematoma and the intramuscular bleeding. So we do a lot of ice and stretch because it's pretty painful because of the compression and the swelling puts pressure on the free nerve endings, which generates the pain. So the big thing is regaining range of motion quickly and safely with ice and stretch techniques. Okay, so here we see this is a femur. So you're looking at a side view. So this would be the hamstrings down here, nice and clear, right? Because the x-ray works because the bone is dense, so it absorbs. This is the quad, and you see severe calcium or calcifying ossificans in the muscle belly. Not good. This is bad. Heterotopic ossification, it means in the wrong place. So usually this is after surgery. You can see a normal left hip, right? Patient's left hip looks very normal. If they had hip surgery and they weren't following their post-op guidelines and precautions, let's say they didn't move it at all, that bleeding in the area and that cellular waste needs to be reabsorbed. So here you see this enormous mass. This is like horrifically bad, covering probably the abductors, the hip flexors. They probably have to excise this, so they'll have to go in and cut out anything that's not quality tissue. Okay, bursitis. So remember, the bursa are those fluid-filled sacs that are usually between a tendon and a bone that reduce friction, that allows the tendon to move nice and freely without restriction. There's a lot of reasons why people end up with inflammation directly in the bursa. You can see this one is right in the area of the tricep where the olecranon and the tricep tendon interact. Of course, a staph infection or a direct blow, those are direct traumas that can cause some inflammatory reactions of the bursa. So basically, we just try to protect them. Obviously, if it's a staph infection, they need to be on antibiotic medications, in which case you're going to need to refer. But if they just fall and hit the elbow and it swells up like that, it's just basic conservative care. So like ice and anti-inflammatories and gentle therapeutic exercise. Okay, so we're slowly moving away from muscles. So we did muscles, tendons, the bursas. Now we're going to talk about sprains of ligaments or the capsule. Right? Don't forget about the joint capsule. Remember, you have the outer fibrous part of the capsule and then the inner synovial membrane. A little bit difference between ligaments. Remember, those are connected tissues that are dense and regular. That means they're in straight lines, regular. Right? Dense means they're tightly packed, so they absorb tensile forces. The joint capsule is irregular, which means instead of the fibers pointing all in straight lines, they're all twisted in different directions. So ligaments handle linear stresses or tensile forces versus the capsule can handle multi-directional, so twisting and rotation in multiple planes. Okay, So the mechanism is typically tensile, especially when it's to the ligaments. And of course, we grade everything. So grade 1, remember there's stretching on the fibers, which means this ligament is still stable. So therefore, they should have a firm endpoint at the end of the passive range of motion. This is going to be very important in the evaluation process and answering questions on quizzes or figuring out scenarios on exams. Grade 1, sprain. The ligament is still stable because no fibers are torn, so therefore it feels firm. With a second degree sprain, here we see a lateral ankle sprain with some edema and effusion. The infeel is soft because they have increased laxity, right? Because of the partial tear of the fibers. So they still might have an endpoint, but instead of being firm, it feels softer. And then with a grade 3 complete tear, so now when you stress those ligaments, they'll feel empty, right? Because if the ligament is torn, there's nothing to stabilize the joint when you move it to its end range of motion. When you stretch it completely, this will feel empty because the ligament is torn, right? So we call that instability or laxity. So subluxation. So where two bones come together, they comprise an articular joint. Right? Remember articular joints? They have a joint capsule. So if it spontaneously reduces, right, that's called a subluxation. Let's say someone is cutting and changing direction. They feel their patella shift laterally and then it pops back into place real quickly. That would be a subluxation. So the patient complains of it popping out and coming back in. So obviously we're worried about overstretching of tissues, right? So particularly the ligaments, because in the patellofemoral joint, the patella is just floating, right? There's no other bone really holding it in place. So the ligaments that support the patella are very, very important. Yeah, and then once it happens, you're predisposed for future events. So that's the concern, is that it becomes a recurrent issue of happening over and over, or then they have full dislocating events. So when you stress the tissues, and so if you do like a lateral patellar glide, they might complain of apprehension. So they feel like it's going to dislocate, or they'll contract their muscles to stabilize. Okay, if you've never seen this view of an X-ray before, it's called a sunrise view. Gotta make sure we get that on mic. A big coffee sip. So if you flex your knee all the way up, right, bring your knee to your chest and imagine the camera is shooting over your shoulder into that fully flexed knee position, right? That's the angle we're looking at. So obviously you can see the joint surface of the patella and the femoral trochlea. So this V shape is the femur. So this is called the trochlea, this V shape. And look at the way the two bones line up, right? They're very symmetrical and congruent, so they match perfectly. In this person, you can see they've got lateral shifting, so the patella is shifted laterally, widened joint space on the medial side, so the ligament on this side is being overstretched, and then we get compression on the lateral side of the patellofemoral joint, right? Very common to have patellofemoral issues due to lateral tracking, and we'll talk about it in, I think, chapter 11, patellofemoral. Okay, joint dislocations. So patella, very commonly dislocated. That's why we're kind of mentioning it now, especially in the lower extremity. Patella is the most commonly dislocated. So of course we worry about, instead of things being overstretched, now they're torn and ruptured, especially the ligaments on the medial side of the patella. So if it was a patella, those are pretty easy to reduce. You got to make sure it's in your scope of practice. So if you're not trained to do it, you're not supposed to really do it. But there's plenty of YouTube videos you can watch. If you just put patellar reduction, you guys can see what it looks like in the hospital setting. The patellofemoral joint is pretty easy because it's like a floating bone. It's just right on top of the femur. But of course, the deeper the joint, the harder it's going to be. So of course you worry about, things around it that you don't want to injure, like nerves or arteries and veins. Okay, and then regardless if it was dislocated, subluxed, or it's out and you're trying to transport them, you always want to make sure that they have a pulse. So remember the two in the foot, posterior tibial and dorsalis pedis. The muscles are working distally. So if they wiggle their foot and toes, we know the nerves haven't been compromised, and then sensory. Okay, so here we see the finger dislocation, probably the most minor. So I think the ones coming up are a little bit more intense. So if you're a little squeamish, you might want to skip ahead 10 or 15 seconds. Okay, so we'll start distally down at the ankle. So here we see a talocrural, right, where the tibia meets the talus, tibio-talar dislocation. Here we see a patella, so lateral dislocation of the patella. So when someone says I dislocated my knee, this is typically what they're talking about. A serious injury, but you know, it's not that bad relative to femoral tibial dislocation. This is potentially life-threatening. So tibial femoral dislocation, the popliteal artery is the one moving down the backside of the leg. And if that artery is torn, so with a knee dislocation of the tibia and the femur, that artery is commonly torn. And if there's severe bleeding, then you worry about, you know, will the patient lose their leg? Will it be severe enough that it could kill them? Because those are very big concerns. And we'll talk about some examples of torn popliteal arteries in the knee chapter. Then here we see this one is the common presentation for a hip dislocation. You can see here's the mechanism. This is Bo Jackson, the greatest athlete who ever lived. If you've never heard of him, he was a Major League Baseball All-Star and a football All-Pro. He's the only person ever to be on both of those squads, right? So being an all-star in both football and baseball. So he had a long axis. This guy was trying to tackle him. He pulled down on the hip, so there was an axial force that dislocated it. He went on to have a hip replacement because the blood supply to the femur was compromised. And then he played Major League Baseball with a hip replacement. So if you don't think he's the greatest athlete ever, that's just more evidence. All-pro, an all-star, only person to ever do that. And then he played Major League Baseball with a hip replacement. It's incredible. Okay, the articular surface. So where two bones come together, remember that hyaline cartilage on the end of the weight-bearing surface of the bones, right? So here we see the knee. That hyaline cartilage is very special because it absorbs compression and shear forces, and it's particularly slippery. Particularly slippery, yeah. That's what I was trying to say. Because it holds more water in its surface, you don't want friction when you're moving through your range of motion, right? Imagine doing like jumping up and down with squats or lunges. You want the end of your bone to be very slippery so that it glides smoothly. When this articular surface gets worn out, either from an acute injury or degenerative changes over the course of your life, currently it's mostly irreversible. There are some treatment options. We'll talk about those. But we worry about the progression to osteoarthritis and then needing a knee replacement. Okay, so in athletes, it's possible to have osteochondral defects. So where, remember, chondral refers to cartilage. So where the cartilage of the bones, you can see here, typically with ACL tears or meniscus injuries, they might be accompanied with an OCD lesion where the articular cartilage is cracked or chipped. So we describe them as either partial or full, right? So if it goes all the way to the subchondral bone. Remember, the cartilage doesn't have good blood supply. So therefore, its healing potential is very limited. That's the concern. And that's why people end up with osteoarthritis or knee replacement because the cartilage has poor blood supply. So it doesn't heal well. Okay, so if we think about the typical, you get compression, which is axial loading, compression. Sometimes it's insidious, so they don't know why. It just deteriorates over time. The best way to know if you're at risk for those degenerative conditions is if you have a family history of knee replacements. So if your parents, grandparents, great-grandparents had joint replacement surgeries, then that's probably like a genetic predisposition, and so you might have increased risk as well. Okay, so here let's look at an example of an X-ray on the left and an MRI on the right. So if we look at this knee, right, the tibia looks very normal, right? So the cartilage looks dense. Here we see the epiphyseal scar. So this is an adult because it's closed. Fibula hanging out down here, and then femur above. So growth plate of the femur closed, so we know it's an adult. On the lateral compartment, the femur looks relatively normal. You can see these two little pyramids, triangle shapes. That's where the ACL and PCL are at. That's why they're pointy. And then there's this weird lucency over on the medial side. And on the MRI, you can see it a lot more clearly. It should look like this, right? It should be white, solid, and then the black line is the cartilage. This is a horrifically bad OCD lesion of the medial femoral condyle. Okay, sometimes little pieces break off. That's called osteochondritis dissecans. So if you get little floaters in the joint space, sometimes they get stuck. So if the person's going through the range of motion, they might hold it in a specific position because that little piece of cartilage that's floating around the synovial fluid gets trapped when you're trying to flex and extend your knee. So they might have episodes of locking or pseudo fake locking events. So the big concern with any of these injuries is that they end up with arthritis, which is a degenerative condition. OA is the most common in athletes, especially the knee is the most common, then hip is second, and then ankle's third, because those are the weight-bearing joints. So there's more force and stress directed to those articular surfaces. Less common form, rheumatoid arthritis. So have you ever seen someone's fingers that the knuckles are really swollen? Usually they're in their 70s or 80s, and they have really trouble with their fingers. That's systemic, right? So that's inflammatory cells in the circulatory system that are affecting the joints, right? So that's rheumatoid arthritis, right? So it's an inflammatory process. Occasionally, but pretty rare, that it occurs in juveniles. Okay, so part of the concern is using x-rays are an okay way of trying to view the joint spaces in arthritis. So let's look at this example. So this is severe OA of the medial compartment of the knee. So the lateral side, you can see the joint surfaces aren't that great. There's some irregular surfaces, so they're not smooth. And then on the medial joint space, there's almost none, right? So when they say bone-on-bone contact, that's what they're referring to. So this person was probably standing. So when you're standing up and you take an x-ray, there should still be a clear joint space, right? Even though when you're standing, because you have the menisci. So here you can see this person has a normal looking x-ray, but let's say they had knee pain. You don't think they have a torn meniscus. You don't think it's the ACL or PCL. Their x-ray could look normal, but the joint is already sick and it's in the beginning stages of osteoarthritis. So let's look down here at the hip. You see normal joint surface. There's good distance between the femoral head and then the acetabulum, right? So pretty normal joint space. But this is an advanced MRI technique that they use in research. It's called degemmaric. So they use gadolinium, which is, they drink this cocktail. The patient drinks this cocktail that has gadolinium in it. Then you wait a few hours while it circulates through the body. And it's attracted to GAG, right? If you've had physiology, you may remember GAG stands for glucosaminoglycans, right? So these glucosaminoglycans, they're in your cartilage and they're what attract water. So when people are trying to map the cartilage, we can't do it directly. We can't look at the MRI and see, oh, there's all the cartilage cells. But what they can do is map these glucosaminoglycans, and then you can do like an indirect measure of how much water is being attracted to those cartilage cells, which is what you want, right? You want it to be slippery because it's a joint surface. So here you see this person who has got a normal x-ray, The redder it is, the worse the joint is, right? So you can see very red, heavy, intense signals on these different slices of their MRI. So in this person who's got a low amount of glucosaminoglycans, they have low water content, the cartilage is becoming sick, right? So if they have hip pain, it could be the precursors of osteoarthritis. Okay, I'm gonna cover the mic on this one. There you go. All right, we're back. Okay, so a couple more terms, exostosis versus apophysitis. So exostosis is a extra bony growth you can see here. Do you guys remember, if this is the calcaneus, what inserts on the superior posterior edge of the calcaneus? You said Achilles tendon, you're right. So you can see this is what your Achilles should look like, right? You can't see the tendon because it's not dense enough to absorb the X-ray energy. So here you can see on this left side, this bony spur that's occurred, right? Obviously, if you have a bony projection in the tendon, anytime you move through a range of motion, it's just causing friction and irritation. So not good. Sometimes it can come down here on the bottom of the calcaneus. So what attaches on the bottom of the foot? If you said plantar fascia, you're right. So right here, some people get bony spurs that irritate their plantar fascia. Did I get all these? Yeah, okay, we're good. Apophysitis can present in similar areas, but this one is unique only to adolescents, right? So here you see in this adult, the calcaneus is solid because the growth plate is closed. Here we can see this isn't a fracture. This is where the growth plate is. Remember, when you're an adolescent and you're growing, that's where the bones get longer. And if you remember from physiology, the growth plate is comprised of cartilage, not bone, right? You convert the cartilage into bone, which makes the bone longer. But because the cartilage is less dense than the bone, it looks translucent on this X-ray. If we get irritation of the growth plate, it can cause pain, right? So this one in the heel, in the growth plate of the Achilles, is called Sever's disease. It's basically an adolescent who's doing a lot of running and jumping. They get growth plate irritation. And then as soon as the growth plate closes, the pain is going to go away, right? So obviously, if they have a history of a growth spurt, you know, the bone and the growth plate or the epiphysis are undergoing rapid changes. And if they're doing a lot of running and jumping, it can cause irritation. Okay, so if you didn't remember any of those, let's review real quick what happens at the growth plate. Remember, the shaft is the diaphysis. And then when it starts to flare, it's called the metaphysis. And then the growth plate is where the cartilage is at, right? So in adults on an X-ray, it looks like a scar. And in adolescents or younger patients, it looks like just a translucent clear line. Then the end is the epiphysis, and then articular or hyaline cartilage living in the edge of the joint space, right? Okay, so now we're going to talk about different types of fractures. This might be a review, depending on your 305 or 415 KRS experiences. So remember, we classify fractures based on, number one, their location. So where did they occur? So we just saw on the previous slide some locations of the bone. The shaft, the diaphysis, the metaphysis, and the epiphysis, and then the growth plate. So those are our locations. The magnitude, the shape, and the duration we'll learn here. So obviously transverse, linear, those are pretty straightforward. Non-displaced means the edges still line up. Right? So non-displaced, both edges of the bone on an X-ray, because those are 2D, right? The bone is 360 degrees, so you have to view multiple planes. But on a 2D image, you're looking at, you know, the two edges. So displaced means you can see this one's probably at like a 45-degree angular displacement, right? This one's angled 45 degrees in varus. And then compound means it's poking through the skin. Spiral, straightforward. If you think about like the barber shop thing that's outside the shop, like or a candy cane, like a spiral fracture. Green stick. So that gets its name from, if you've ever taken a very young branch on a tree, so not a mature tree, but one that's still growing, if you bend it, it kind of splinters on the tension side, but the compression side doesn't change. So that's called the green stick. It gets its name from a young tree branch. And then comminuted, I always add an extra I, comminuted. That's one that always gets me. So this one is usually a compression fracture where we get a lot of little pieces, so 2 or more broken up little pieces, which makes the surgery to heal it a little bit more complex. Okay, so some locations, we might get some interesting images. So if you're queasy, keep you on your toes. So here we see a complete, right, because both edges are broken, a complete shaft fracture or diaphysis. And it's probably about 30% displaced. So obviously to get this back aligned, you're gonna have to do traction to pull it down and then slide it back up and over. One's through the growth plate epiphysis. So here you see a normal right hip on the patient. So they're sitting in a frog leg position, so the legs are externally rotated. You see the femoral neck, nice and straight, and then the head on it like an ice cream cone. When we look at the injured side, you see there's a total loss of the offset here. So this is the metaphysis, the growth plate fracture, and then the head is drifting posteriorly, right? Because the metaphysis is moving anteriorly, right? So if you think about the ice cream on the cone, it's sliding off. Very dangerous, right? This is a very severe fracture because this person, if it's through the growth plate, they have to be an adolescent. So now you start worrying about the health of this joint the next 40, 50 years of their life. Okay, so here's one where I said you got to be careful. I always forget, like practicing for 15 years, I'm pretty desensitized, having seen all these in real life. Okay, so incomplete, complete goes through each side, and then of course the open and fracture dislocations. Okay, so we hit all those. That's a little bit of a review. So green stick, fissures, comminuted, transverse, oblique, and spirals. Okay, so when we're evaluating these injuries, obviously you want to feel the bone for point tenderness. If they're in like a significant trauma and it's obvious, you don't have to palpate it. You can just refer them, right? If you suspect they had an acute traumatic event that caused a fracture. But for more subtle ones, is it point tender on the bone? Do they have radiating pain? Because those are some of the red flags. Stress fractures are more subtle. So obviously these are going to be overuse in nature. Remember back in physiology, we talked about all the hormones that control the skeletal system, calcitonin, vitamin D, getting enough sunshine, having adequate nutrition, because when we lay down new bone, that's the osteoblasts. And if you remember, we need to constantly break down the skeletal system because it has something very important in its bony matrix. So what in the bony matrix of the skeleton do you remember being very important? So we said calcium, you're right. Remember, calcium is also required for skeletal muscle contractions. So let's use the example of you go to work out at the gym, you're going to do heavy weights, or you're going on a very long run and your tibia is constantly breaking down. The concern is that you need the calcium for your skeletal muscle contractions. So when you have a decrease in your bloodstream of calcium because the muscles are taking it all in, the body will start to break down the skeletal system to raise the blood level of calcium, right? So that's why there's an important interplay between nutrition, activity levels, overuse injuries. Those all need to be considered. The concern is that the fracture line, instead of being just like a softening of the bone, that it becomes a full-blown fracture. The trouble with the stress fractures is sometimes they're point tender and sometimes they're not. Like I've had some really weird cases where, you know, it's a distance runner, cross country or track and field, and they're complaining of pain in the bone. And then when you palpate it, you can't find anything. The range of motion and strength is totally normal. Like you literally can't find anything. And then you start worrying, like, do they have bone cancer or is it a stress fracture? Because it can be possible to have bone cancer that presents like a stress fracture. So at that point, you just want to make sure they're getting worked up for the right diagnostic tests. Okay, avulsion fractures. So either a ligament or a tendon pulls away bone from bone, right? So tearing away of the bony attachment. So this is the quadricep, patella, which is unusually small in this diagram, a very small patella. And then you see the patellar tendon on the tibial tuberosity, so shearing the tibial tuberosity right off. You gotta be careful that you don't mistake it for a strain, because these are typically in hips or knees of younger athletes, adolescents. They're going to be point tender, there's going to be some swelling, the motion's going to be limited, and it might only feel good to totally shorten the joint because it'll push the fracture back into place. So imagine if you had right in the front of your ASIS, if you sheared away the sartorius muscle, remember that's on the ASIS. So to shorten it, they'd have to flex your hip all the way, and then that might relieve their pain because you're compressing it back down. And then as they try to straighten their leg, it's going to hurt because you start pulling and creating more tension on it. All right, last couple little slides. Compartment syndrome. So if we think about the anatomical nature of, let's do the posterior compartment, the deep posterior compartment in your shank or in your lower leg, there's a certain space that's created by fascia, right? So the connective tissues, because we have the arteries, veins, and nerves and muscles that make up that compartment or that area. If we get changes in pressure, it can cause compression of the neurovascular bundle, right? So nerves and arteries and veins. Some people, they go for a run, right? Exertional compartment syndrome. They go for a run and they start to feel pressure build up on their legs. So here we see two people. So obviously this person, right? This is the amount of time they're exercising. And this is the pressure. Remember, that's millimeters of mercury. So one person goes for a run, they get an increase of pressure because there's increased blood flow to the area. Right? So as you begin to exercise, there's more blood flow because the muscles need more oxygen. You're trying to clear the waste and the hydrogen ions that are accumulating from ATP use, electron transport chain, right? You guys remember that. So as this person begins to exercise and then they stop, the pressure normalizes. Some people, it spikes more rapidly. So because the compartments are confined spaces, because of the connective tissue and fascia that hold them in place, if the muscles hypertrophy, if they have deficient venous return of fluid, that can make the pressure spike, right? So exertional means there is no traumatic event. They just go for a run and their leg feels like it's going to explode. Yeah, so that's during exercise. Okay, yeah, so lower leg is the most common, especially in the deep posterior compartment where you have all your toe flexors and ankle inverters. The concern is, you know, exertional, you try stretching, you try rehab, conservative measures to try to treat it. Sometimes they'll go in and cut open the compartment and they'll release the fascia. They call it a fasciotomy, where they just cut open it so that there's more space in the compartment. The concern is if you get acute compartment syndrome, let's say you have a lower leg fracture dislocation, or you have a very traumatic blow to the lower leg and it starts to fill with blood and it starts to swell, you might start getting the 5 Ps, right? So obviously it's going to hurt. And then we worry about pallor, which is lack of color, right? Pallor. Pulselessness. If they lose the pulse, that means the blood flow has been compromised. Burning, numbness, tingling, which indicates the nerves are compressed, and then the muscles stop working paralysis, right? So the 5 Ps of compartment syndrome, typically acute compartment syndrome, right? Because then you start worrying about, are they going to lose the limb, or are they going to have a loss of life? Because compartment syndrome could be life-threatening when it's acute and severe. All right, so that wraps up injury nomenclature. I'll see you guys next time.